Okay, so on the study guide, we talked about, it said what's unique about their temperament that makes anesthesia challenging. Um, they can be very excitable and nervous. There are stoic breeds, but horses overall are flight animals, so they're kind of always on guard. They're always a little skeptical. Um, and so very much paying attention to their temperament. And the other thing about their temperament is their need to stand. And so when you recover them, sometimes they try to stand before they're technically ready. So being prepared to do extra things on recovery to make it safe. For number two, what size patients use a small animal machine? That's going to be if they're less than 300 pounds. So if you have a pony, a foal, a mini horse, as long as they're under, excuse me, as long as they're under 300 pounds, they can use the small animal equipment, small animal breathing systems, small animal bags. And what physiologic challenges do they present? The big thing is they have to be able to breathe through their nose. They're obligate nasal breathers. Also, the fact that they have a large GI tract that pushes on their lungs that can produce atelectasis. So these areas of collapsed lung, or better answer is collapsed alveoli, if they don't inflate their lungs fully, they're going to have some degree of atelectasis. This is why we do manual ventilation. And if I've not mentioned it before, which I believe I have, I'm going to type it here, is if you put a horse, if you put any animal on a ventilator, you're doing what's called CPPV, which is continuous positive pressure ventilation. Anytime you bag an animal, like in surgery, when I say bag every 3 to 5 minutes, you're doing what's called IPPV, which is intermittent positive pressure ventilation. That's the fancy way for saying bagging the patient. When you put them on a ventilator, they are, sorry, my dogs are wild this morning. When you put them on a ventilator, you're doing continuous positive pressure ventilation, and you're giving positive pressure to the lungs, and that's what that means. So horses, again, I said you can't really bag them. They need to be ventilated. They're also susceptible to colic due to, anesthesia slowing everything down, slowing down the GI tract. So we want to avoid drugs that cause that. And neuropathy and myopathy. Now, the big reasons they get neuropathy and myopathy is the inadequate padding, tying the legs, inadequate hobbles, but they can also get myopathy from inadequate perfusion, which is their blood pressure. So we have to make sure we pad them well, support blood pressure, support ventilation, make sure they can always breathe through their nose. Now, again, when a horse is intubated, they're not breathing through their nose. They're breathing through their tube, but there's a period of time where you might be recovering them in a stall and you don't want their nose against the stall or in bedding. And especially if you're in the field and you're, in a stall at a farm, you just want to make sure that their nose is always clear of debris, make sure they don't have excessive nasal discharge. Be familiar with procedures that are appropriate for standing, light sedation. So the 3 levels of anesthesia. So standing light sedation is just sedation. Kind of like if you just give a dog ACE and butorphanol, what could you do? Well, in a horse, you could do ultrasound or float their teeth, put in a catheter. If we do what's called standing chemical restraint, that is more profound. And kind of like what you guys did in radiology, you did dexdomitor butorphanol at a higher dose IV, and you had those dogs pretty much asleep, but they weren't fully anesthetized. Now in a horse, you want profound sedation, but we don't want to drop them. We want them standing. So this would be, you know, maybe eyelid surgery, potentially castration, ovariectomy, mass removal. So maybe more advanced procedures where you need more sedation. And when we go to TIVA, that's total intravenous anesthesia. Now that could be, I would say more castration would be TIVA. You need them pretty much asleep. But you're not, when you do TIVA, everything is intravenous. Well, you might give an IM pre-med and then go intravenous, but you're not using any gas anesthesia. You're not using ventilators. You're maintaining anesthesia with only injectables. So TIVA is also known as field anesthesia. And then you have general anesthesia, which would be the injectable protocol going on to intubation. And that would be like colic surgery. If you're doing anything to a joint, like a joint scope, joint surgery, fracture repair, where you have, you know, if the horse is going to be anesthetized longer than an hour, and this is why you need to know the procedure and the condition of the horse, they're going to need more monitoring. They're going to need oxygen support, ventilation support, blood pressure support. It's really not appropriate. You're not going to do a colic in a barn. I'm just going to say that. That horse needs to be in a hospital, in an OR. So what do we do to prep the patient for anesthesia? So obviously, you know, there's getting equipment ready. That's one thing, because you have to get your machine, your crash cart, your catheters, your surgical equipment. You have to have everything set up. When you anesthetize a horse, things go quickly, you know, so you don't want to have to be setting anything up. You want to get everything set up. That's kind of like, and when you guys go into surgery rotation, I like to sometimes, you know, you get your drugs ready, you pre-med your patient, and then you have time to set stuff up while your patient, I call them cooking. You know, obviously they'll tell you the order you need to do things, but sometimes when I have a patient pre-medded, that's when I go and I set up all my stuff. As far as getting, you know, the machine ready, it is the same parts, the same theory. It's just bigger, larger tubes, 15 and 30 liter bags. But one thing, this is the slide. So slide 11 is sedate to put in the IV catheter in the jugular vein. You got to wash out their mouth from any food, and pick out their hooves, clean their, you know, their hooves, and maybe wrap their feet so that, you know, even if you clean them out, you're not going to get them perfectly clean. So we usually cover their hooves with bandage material or like shoe covers. We even use shoe covers fit over a hoof as well. And how do we choose a protocol? Well, it kind of goes up here, but basically it's the same theory as any patient. What is their history? How old are they? Do they have any concurrent disease? Evaluate lab work, but also the temperament. And, you know, if you have a stoic horse or if you have a very ill horse, you know, some colic patients come in very, very sick. That's going to be a different protocol than if you have an Arabian, a 2-year-old Arabian for a joint scope. You know, Arabians and thoroughbreds are extremely flighty. I really don't like working with either of those horses. They're just very on edge, but you might have a big old quarter horse or a draft horse that's very relaxed. But again, the procedure, if it's going to be short, you might use TIVA. If it's going to be involved, you're probably going to do injectable and inhalant, and that's going to help also pick your protocol. So number 7, what are induction agents bolused instead? Or why are agents bolused instead of given to effect? So the problem with horses slide 15, is you need to drop them quick. We don't want them going through, you know, you're very rarely going to use you might use propofol on like a pony or a foal. Very rarely are you going to use propofol on an adult horse. I'm not sure about alfaxin, if people are using alfaxin, but the problem is those drugs are quick agents. They don't hang around. And when you drop a horse quickly, we also need those drugs to hang out. So you typically use ketamine with an alpha 2, sometimes mixed with an analgesic, or maybe the analgesic was given before, but you need, it's a bolus technique. You're giving everything because you need to get them anesthetized and dropped quickly. So it's not, if you saw in that first video we watched, they gave those drugs pretty rapidly, and that horse went down pretty predictably. Can we use inhalants for induction? Technically, no. You're not going to use an inhalant for an adult horse. You're not going to mask a horse down. Now, you could have a sick foal and potentially do that nasotracheal intubation, and they inhale the inhalant through the nasal tube. You could potentially do that. You could put a mask. They do make large masks. You could potentially put a mask on a foal, but it's easier to do it via the nasotracheal intubation. But adult horses, you're not going to do that very quickly. Number 8. Oh, sorry, I skipped that, Heidi. The only agent, what is the only agent we give to effect? Why don't you guys tell me? There's one agent that we can give, that we give to effect.
I suck at pronouncing it, but guaifenesin.
You said it. That's right.
Oh, yay.
Yay. You get the award of the day. Yeah, guaifenesin. So guaifenesin is part of that triple drip protocol. It can really be given in any protocol, but it's part of triple drip. And guaifenesin is a muscle relaxant, and that is given to effect. It's not an anesthetic, but it's used. And again, if you buy a box of Mucinex, if you have a cold, guaifenesin is one of the active ingredients. And the reason we use it is it loosens up the muscles in your bronchioles and helps you cough up mucus. So that's why it's part of those Mucinex drugs or cough medications. But it is a muscle relaxant. So guaifenesin is the only one you give to effect in a protocol. Explain the process of intubation, be familiar with size of tubes. So the nice thing about horse intubation, and let me skip to that slide. So the tubes, number one, the tubes are extremely long. They're in like size, like you get into 22, the 24, the 26, but they're long. These are the silicone tubes. And it's a blind intubation, meaning no one is opening the mouth and holding the head up, and you're not looking at the larynx. You're literally going to pull the tongue out of their mouth, and you're going to slide the tube in. And so it's done by feel, but what I mean by feel is you're not feeling back there. You're literally just feeling if it go, if it goes in easy. Now, what's important that I told you is, how do you confirm? Did I make a question about that? No. So, but this is part of intubation. How do you know you're in the right place? Because you always have to confirm intubation. Well, normally what you do, if the tube slides in easily, is usually someone will push on the horse's chest, and you'll put your hand in front of the tube, and do you feel air? Or the horse might exhale and you feel air. But usually someone goes and kind of pushes on their chest, and then you feel air. You're not going to feel their neck. And length is not an issue, because you can see how long a horse's neck is. You're not going to go beyond the thoracic inlet. So you don't have to feel for, one tube. You don't have to feel the position. Is it too far? It's not going to go too far. But you do need to feel for air. You might be able to see fogging, although sometimes in these silicone tubes, even though they're kind of see-through, they're cloudy. It's not easy to see humidification. The clear tubes that you guys use in dogs and cats are very clear, and you can see when they exhale. These tubes are difficult, so you need to really go by feeling air. That's going to confirm if you're in the right spot. But it's really fairly easy. You put a mouth gag in, slide the tube in, don't have to worry about going too far. What are the indications for nasotracheal intubation? What are common complications? So, so here's slide 24 goes through the process. Now, nasotracheal is the ventral nasal meatus, the tube goes all the way to the trachea. If it's nasopharyngeal, that only goes to the back of the throat, which is the pharynx. If they're doing something to the head and neck, or maybe to the mouth, and you can't use the mouth, then now in an adult horse, you're probably going to induce them and then pass it. We did talk about foals using nasotracheal as induction. But an adult horse, you need to do the induction and then place a nasotracheal tube. And obviously, you're going to use a long tube, but it's going to be a smaller diameter. Obviously, if it's going through the mouth, you can use standard sizes. If it's going through the nose, it's going to be more narrow. Complications, well, anytime you put something in the nose, well, a small animal, so the same thing, like potentially vagal stimulation, potentially trauma to the trachea, you know, all the same complications I talked about in small animal. But if we're talking about nasal intubation, we do worry about epistaxis. You would worry about blood clots in their nasal cavity. But this is why I will tell you, more than likely, most of the time you're going to be using those silicone tubes, especially if you're going through the nose, because they're softer. They're going to be less traumatic to the nasal cavity. They're easier to put in. So, but you do have to worry about epistaxis. Sometimes their anatomy, if it's a mini horse, it may make it more difficult, or if they have oral nasal cavity disease. But I do want you to know epistaxis, which is the fancy term for nosebleed, but I would prefer you write the word epistaxis and not put nosebleed on your test. I mean, you guys are far enough along that you know stuff like that. So, what are 3 common complications horses are more prone to developing during anesthesia? Now, I stressed these the other day. So slide 28 for number 12, but you got the 3 hypos. Think of them as the 3 hypos: hypoventilation, hypotension, hypoxemia. And this goes back to monitoring. So hypoventilation is not breathing often enough or deep enough, which is extremely common in horses that are anesthetized. So how do I fix that? It says right here, you mechanically ventilate. You don't even let them develop it. But what is an indicator of ventilation? How do we monitor ventilation under anesthesia? What value am I going to monitor? And you are doing this in 3 weeks.
The end tidal CO2.
End tidal CO2. End tidal CO2. I would really be starting to review this stuff because, again, 3 weeks, and you know, you're going to have, especially if you're using a ventilator, you need to have an end tidal CO2 monitor. That's going to tell you if your horse is ventilating, the only way to get rid of CO2 is to ventilate. So if they have too much CO2, they're probably not ventilating well. And you need to, and that's how when I work with ventilators, that's how I gauge my ventilation. That's how I adjust my ventilator. Because I also you don't want CO2 too low either. Sometimes I turn on a ventilator and all of a sudden my CO2 is 20 because I'm doing too good of a job. And I'm like, whoa, okay. So then I kind of back off my settings. And you would get advanced training again, but I think the theory of what is ventilation, how do we monitor it? You monitor CO2. And a lot of people want to say oxygen, and oxygen has a relationship, obviously, to ventilation, but CO2 is a more sensitive monitor of if they're doing a good job ventilating. Now, hypotension, you do need their blood pressure above. Now, what this slide is saying, and Bethany asked a good question the other day, this slide is not saying you want it on less than 70. It's saying hypotension is anything lower than 70. So in the horse, it has to be 70 millimeters of mercury. CO2 has to be 35 to 45. And then your oxygen levels, if you're using an SpO2, a pulse ox, you're going to want your readings 95 to 100%. This reading is off of a blood gas from an arterial sample where you would want it up, you would want it above 80. If you're measuring arterial, this is how much oxygen is dissolved in plasma. When you talk about a pulse ox, that is how much hemoglobin is saturated with oxygen. They're both measuring oxygen. They're just measuring two different forms of oxygen, two different ways. So if you see PA, think arterial, and SP is saturation. That kind of gives you the clue of what you're monitoring. And then, like I said, how do you treat? You know, part of the equation is it's okay to say, I know what this means, but hypoventilation, you ventilate them. Hypotension, I talked about lowering your anesthetic, turning up your fluids, potentially. And again, the consequence is myopathy. If you don't get perfusion to the muscles, you're going to, you know, have problems. And then hypoxemia is also ventilation. You're going to have to help ventilate. And again, it's more common if they're obese or pregnant, have a colic, you know, that contributes to. I was like, Haley, you either fell asleep on your
No, this cat just like jumped on the keyboard.
No, that's, I know it happens. Someone else did that in my other class, and we all got to laugh.
Like, I'm not crazy. So.
No, I was like, Haley really wants to say something, but I don't know what she wants to say. But no, you're totally fine. Trust me, my animals don't cooperate with me, so I get it. So it said, how for 13, how do we position the equine during anesthesia surgery? How do we position if they're in lateral? So for positioning, remember, if they're always padded, whether they're in dorsal or lateral or whatever. If they're in dorsal, also, you don't want to hyperextend the limbs. You want to have the limbs in a natural position, a padded halter if possible, because if you leave the halter on, buckles and things can compress facial nerves. If they're in lateral, the limbs cannot be touching. They need to be spread apart in a scissor formation. Even if they're not scissored, they still need, you don't want a limb laying over a limb. That doesn't help them ventilate, but it also puts pressure on superficial nerves, and that contributes to neuropathy. So that's very important. What's the difference between direct and indirect? So just to remember, any indirect blood pressure is an estimation. So that would be a cuff on a limb, which is oscillometric. A Doppler is indirect blood pressure. A Doppler only gives you systolic blood pressure. So it's just an indicator. It's an estimation. If you want to, though, in a horse, because blood pressure is so key, this is direct. So it's a catheter in an artery, and it uses a transducer, but because it's in the artery, it's measuring blood pressure directly. So you can use either the facial artery, which some people say, the mandibular artery, since you find it on the mandible. The transverse facial, now that's the one under the eye. And then, the dorsal pedal, which if they're doing something to the head and neck, you can use. And these are superficial arteries. These are also the arteries that, remember I said right after you induce a horse, somebody needs to feel a pulse. It's hard to feel their heart. It's hard to listen to their heart. So it's easy to just put your fingers here and use that to palpate an artery. And the other thing I will tell you guys, I've mentioned this, arterial catheters are only for monitoring or getting an arterial sample for a blood gas. You don't give drugs in the artery. that can cause cardiac arrest. That can cause a lot of complications. And these catheters are usually pulled like maybe 5 or 10 minutes before we're going to recover them. Like they don't go to the stall with these catheters in. These are just monitoring catheters for the procedure, not for like anything post-op. So they're typically pulled, unless you wanted to do blood gas monitoring post-op, you could potentially leave them in, but you don't want to risk them coming out, because anytime you accidentally stick an artery or on purpose, when you pull those, they bleed more. You have to hold them off probably like about 5 minutes for them to clot, because they're pumping, so they tend to bleed more profusely. And so I already told you which superficial arteries. What are the challenges of recovering a horse? So again, recovery is, we already talked about triple drip. So triple drip is, I don't think I put a question on here lower, but triple drip is ketamine, an alpha-2 like xylazine, and typically guaifenesin. It can be a different alpha-2, romifidine, ditomidine. There's a few large animal alpha-2s, but xylazine is one. And recovery is going to, so here's those questions. But again, their need to stand is a problem. They have to be able to breathe through their nose. So once you pull the endotracheal tube, they have to be able to breathe through their nose because you've taken their airway. So you want to use padded stalls. You can't really stay with them a long time. You can't be like, oh, hi, horsey, are you okay? It's okay. I mean, once they start paddling and trying to lift their head, you pretty much have to get out of the room. So you can't really sit there and soothe them, talk to them. And what can we do to assist recovery? So some of the assisting recovery is we can do the rope recovery, rope assisted recovery. If they're having difficulty breathing, we can use a nasopharyngeal tube. And if they need oxygen, it says, when do we use an oxygen demand valve? That was in the video. They hooked that it looked like a button, but they hooked it to the end of the endotracheal tube, and it's oxygen. And if you give it, it's kind of like a flush valve almost hooked up to the tube, but that's to assist ventilation and give oxygen support. What is nystagmus? Why is it detrimental? Nystagmus means their brain and their body are not caught up. And those are the horses we worry, because if they're already paddling and trying to lift their head during nystagmus, they're going to roll, they're going to fall, because their eyes are trying to find the horizon. What I say is a fixed, if you've ever been dizzy, doesn't someone say, look at something and try to focus on that, which is not always easy to do. You can try to find a fixed point and try to keep your head up. But with nystagmus, if they stand, they follow their eyes. And so we usually don't want them standing until nystagmus is diminished. And again, you can assist them. It says, how can we prevent a horse from standing prematurely? You can sedate with like acepromazine, potentially xylazine. You can put your knee on the back of their neck and hold their head up. That's another way that we can prevent them from standing. But really, if they're trying, much less of giving them a sedative, there's not a lot you can do to restrain a horse. When can the horse eat or drink? So they can drink right after surgery. They can usually eat after about 3 hours. And so they usually do that basket muzzle. And again, sometimes there will be different cases. This is obviously up to the doctor, but general recommendations are give them water, which they can drink through their basket muzzle. The basket muzzle just prevents them from foraging or getting any feed that, because again, they have to be able to grasp their food, and they can't really do that through a basket muzzle. And then what are signs of colic, neuropathy, and myopathy? So these are the ones we worry about. Oh, the other thing you can do when they're recovering, so here's the nasopharyngeal tube to assist ventilation. remember, it doesn't always have to have an oxygen demand valve. It can just be, it's an open airway. And this can stay in longer, but you can also cover their eyes with a towel. Sometimes that keeps it dark and helps them remain sleepier a little bit longer. But neuropathy, you want to watch recovering, watch respiratory rate, watch color, eye position. So we talked about ideal recovery. So for neuropathy, any lip drooping, eyelid drooping, any not being able to extend the limb. So any abnormal limb movement, facial movement are signs of neuropathy. Now the myopathy tends to be they're walking very stiff. The muscles feel hard. And sometimes, and then colic is usually, again, you might say not eating, but the thing is, if we're not feeding them for 3 hours, what are you going to tell me? How are we going to know if they're having a colic if we're not feeding them? So I'm kind of talking about immediately post-op, but it's typically rolling, kicking, or biting at the abdomen. Don't say abnormal gut sounds. You can't see abnormal gut sounds. They can look a little bloated. But again, that's hard to tell because they have a really big abdomen anyway. So those are some signs. What questions do you have from this? What questions do you have? Do you have any questions from the pain local anesthesia section that maybe you want to go over, that something that confused you on the test? Let me see.
I do.
Okay.
So it's an easy question for the answer. What is the importance? And I feel stupid asking this.
No, don't.
Why are we monitoring the patient 5 minutes after? What's the main thing? I thought it was just making sure that they're breathing on their own.
Well, so you mean like right after you extubate, why do you continue to monitor the patient?
Correct. Yes.
Yes. So what you're really watching for is when you, first of all, you want to make sure they're doing okay. But the big thing is when you pull their airway, can they maintain the same type of respiratory rate and effort? I'm really looking for a change in effort or a rapid change in rate. Like if you take an airway, and even if they're swallowing, what if there was like a mucus plug? What if something was at the end of the tube and it came off, and then all of a sudden they're abdominal breathing, or they start to look blue? Or so I'm kind of making sure that it's still a normal, relaxed respiratory rate. There's not an increase in effort. And that's the big thing, because ideally, yeah, you want the heart rate, and you want to make sure their reflexes are coming back to normal, because it is rare, but I've seen a few patients where we've had to like pull them out, potentially re-intubate, potentially take them back to surgery. They started bleeding out. And it was like, what told us that was they started becoming more sedate, or their color changed, or they were breathing strange. There was something that was not predictable in recovery. So normally they have more reflexes. They sometimes wag their tail when you say their name. But I want to see a nice, relaxed respiratory rate that doesn't look much different than when they had the tube in. Does that make sense?
Yes, it does. Thank you.
Mm-hmm. Good. Yeah. There's a little bit on that canine feline anesthesia, and then the pain management. And one section is, when in the pain section was the different types of blocks. Again, a ring block for a D-claw. If it's infraorbital, it's probably something with the eye. If it's the brachial plexus, it's something with the forelimb. If it's an epidural, it's something with the hind limb. The block location can give you a clue as to why we would do that type of block. And one question, I'm glad I thought of this, but the reason that we use preservative when we do an epidural, and you're giving it in the space around the cord, you're behind the spinal cord when you do an epidural, but you're kind of bathing. But some of that, if you push too fast, can go up the cord. But we use preservative free because we don't. First of all, drugs with preservatives are usually multi-dose vials, and we worry about multiple people pulling out of that bottle. There can potentially be contaminant, but we're really worried also about reaction to the preservatives. So normally when we do epidurals, we do preservative-free morphine, preservative-free bupivacaine, single dose vials, and that vial is just for that patient because they tend to react, they can react to the preservative. You might see epidurals with preservative drugs, but again, that's just a caution. If you're going to be the most accurate or the safest, you would use the preservative free. Heidi, did you have a question? I see I do.
Sean asked the question I was going to ask.
Oh, okay. Yeah. So the big thing is, I've seen it too many times, is so many practices do this, and it's a thorn in my side. They pull a tube and they walk away. And again, it's a very dangerous period. We have found animals dead in the cage. So, and usually if I stand there for about 5 minutes and they're breathing at a normal rate, a normal effort, they're blinking well, they have jaw tone, I pinch their toe, they pull their paw, those are all good signs that they're coming out of it. And not that you don't look at them after 5 minutes, you may be there longer, but I've just seen too many practices where people get complacent and pull the tube and think they're done. And in veterinary medicine, too many people are in a hurry. So that's my thing, is like, just take 5 minutes to stand by your patient. And obviously, if it's a brachycephalic, you're going to be there for a while. So those guys, you really, really got to make sure that they are breathing. Like I said, most bulldogs, I don't pull their tube till they can stay sternal on their own. You can prop them up sternal. We used to use paper towel rolls and sandbags, and you can use fluid bags. There's lots of ways to keep your patient propped up. But a good patient, it's like putting a baby in a crib. You're not going to put a baby in a crib on their stomach if they can't lift their head. Because what if they can't breathe? Can they move themselves? Can they get them in a position where they can breathe? And that's the same theory of a brachycephalic. It's like, I don't want to pull a tube and walk away and they fall asleep in a funky position and then they can't breathe. What other questions? Okay.